Hello and welcome. This is your brain on drugs, and this is the punk rock psychiatrist. All right, so moving back to our season on obesity medicine, I actually prefer to call it metabolic medicine or metabolic health because it's not so much about size and weight that matters. And I talked about this in the first episode. It's more about the health aspects that often do go along with that weight, but sometimes happen despite weight and sometimes don't happen with higher weights. So, today, what we're going to talk about are some of the comorbidities, actually, a lot of comorbidities with obesity. I'm not going to go into detail on these, but we're going to go through them slowly, but like not too much detail, just to kind of let you know what all is out there that can cause that can be effects of obesity. And then we're going to talk about doing an assessment. So, kind of the patients come into your office the first time. This is something that you're addressing. Before you would treat it, what would you do? All right. So, those are our topics for today. And then we'll get into some of the more exciting stuff next time where we start talking about the treatments. And don't worry, we're talking about lifestyle first. I don't know if that's what you wanted to hear about, but I think that's what most people definitely want to hear more about just in general. And the great thing is when we talk about lifestyle stuff, the stuff I'm going to talk about, it treats like a lot of stuff, not just obesity. So that's going to be applicable to a lot of things. And then we'll go through meds after we get through that material. But let's go ahead and start off by talking about stuff that happens when you have poor metabolic health that's associated with, which is, very often associated with obesity. Um, I think one thing, whenever you talk to patients about smoking, I think what patients know is lung cancer. That's something that most patients, you ask, why shouldn't you smoke? They'll say, lung cancer. But, and some of them might think about emphysema, but how many think about bladder cancer and colon cancer? And how many people think about cardiovascular disease and diabetes, right? Like smoking wrecks your entire body. How many people think about the fact that it makes you age and it kills the collagen in your skin and gives you wrinkles, right? I mean, I think people might be familiar with some of these things after you bring it up, but they may not be familiar with all of them. And there's so much more. And so, like when I talk to patients about smoking, I like to make sure that they're aware of all the things that can happen, not just the one or two scary things, but the 20 scary things. And I think the same thing goes for obesity. Obesity is like a toxin in your system. It affects absolutely everything, just like drugs, alcohol, smoking do. So let's go over these. So, first off, is just to say that it increases all cause mortality, right? So, for those of you not familiar with that, what does that mean? That means that mortality means death, all cause means by any cause, right? So, essentially, if you're obese, you have an an increased rate of death caused by like basically all factors. I mean, I'm sure it's not every single one, but all cause mortality basically means that you have an increased chance of dying from lots of different things. And obesity is something, smoking would be something else that increases all cause mortality, right? So obesity basically can cause just about anything that shortens your life. And then I've broken it up into categories that we're going to go over to talk about basically every organ system in the body and how obesity can affect it. So first, some metabolic stuff. Mostly here, it's going to be diabetes. I mean, obesity is a metabolic disease, but when we're talking about metabolic diseases that can be caused by it, some of these, there's overlapping things here, but in the metabolic category, I put type 2 diabetes. And the bad thing about type 2 diabetes is it in itself causes a lot of problems. Dementia, retinopathy, so that's, affects your vision, renal failure, heart disease, right? neuropathies, right? So diabetes, which is damage to your nerves, which can cause you not to feel things, and then the cardio, I mean, the heart disease is huge, because that's not just your heart, it's your vessels, and your vessels go everywhere. And when your vessels are sick, it can hurt your body no matter where they're at, right? So diabetes is another one of those all cause mortality things, and obesity increases your risk of diabetes. So something with all cause mortality is now increasing something else that causes all cause mortality. This is one of the worst things that can happen, that you're at an increased rate of if you have obesity. All right. And then some immunological stuff, just inflammation in general. Obesity increases your inflammation. We talked about that on the first episode. It'll come up throughout this series, but basically, inflammation is something that is good for your body when it comes to targeting something that shouldn't be there, right? So, like if you've got an infection or something like that, your body gets inflamed to fight it off and kill it and get rid of it. But if you have systemic, chronic inflammation, where basically your body's just inflamed, but it's not necessarily fighting any particular poison that it needs to get rid of. It's just being caused by illness. Often this is caused by an autoimmune disease, would be one reason. So you like say with lupus, your body is basically attacking itself, and so it's inflamed everywhere. Obesity also causes system-wide inflammation, and that includes inflammation in the brain, which can affect mental health stuff. So a lot of the stuff on this list um, is is affected by that chronic inflammation, right? So that's going to play a key role. So like essentially, we're increasing our immune system is overreacting because of signals that are caused by these excess fat cells, right? Um, and then here's another one I had. COVID is pretty clear in our rearview mirror. Fingers crossed for now. But as you remember, when COVID was going on pretty heavy, those with obesity had more severe COVID and higher rates of death. And so this is one example of, you get sick and you don't quite fight it off as well, right? So on the one hand, we've got increased inflammation because our body's kind of doing too much, and then it's also not doing that good of a job fighting off what it actually should be fighting off. So you had a lot more people that were passing away from COVID that were obese, right? And that could be the case with other types of infections, right? Let's move on to gastrointestinal issues. All right, so I've mentioned this in the last one. We talked about MASLD, that's metabolic dysfunction associated steatotic liver disease. Used to be called NAFLD, non-alcoholic fatty liver disease. So this is when we're depositing fat in our liver, and so like if you're taking in more calories than you can hold, than you need. Remember in the last episode I talked about how you can put fat in your subcutaneous, like underneath your skin. You can put it in amongst your internal organs, the visceral fat, and then it can also be deposited in your liver. That's one of the worst places to put it because your liver just can't handle it being in there, causes inflammation. And then at some point you can actually get MASH, which is metabolic dysfunction associated hepatitis. Used to be called NASH, non-alcoholic steatotic hepatitis. And that can lead to cirrhosis, which is eventually your liver is not going to function anymore, right? Because you're causing this inflammation. The inflammation in the liver is killing the cells that are in there because your immune system is reacting to it over and over again. And then it becomes fibrotic from all of the damage. And then those healthy liver cells are basically replaced with fibrotic tissue, and then your liver doesn't work anymore. So obesity can lead to liver failure, which can kill you. Next, gastrointestinal disorder, GERD. That's gastroesophageal reflux disease. So that's like heartburn, Um, it's basically when acid from your stomach is kind of pushing through the the sphincter that's connecting your esophagus to your stomach, that becomes loose. The acid slips through, it gets into tissue in your esophagus that can't handle having acidic tissue in it. Like the stomach has protective coating that it uses to protect your stomach from the acid that it needs to break down your food. Your esophagus is not intended for that. um, that can lead to pain, but it can also lead to cancer. It can lead to um, some, ulcerations, some severe problems. All right. So that's increased by obesity. And then the last GI issue that I have on here is cholelithiasis, which is um, gallstones. So that's also increased by obesity. Next, moving into genitourinary, um, male and female infertility. So, being obese can make it harder not just for females to become pregnant, but it also affects male fertility. I think it affects female fertility more, but I'm not 100% sure on that. But I do know that it affects the fertility. So if you're trying to get pregnant, you're trying to have kids, it can be harder if you're obese. Next, polycystic ovarian syndrome, PCOS. That's a female issue, obviously. Um, it's that's one way in which you can have fertility issues as a female, and that's why I think it's more affecting female fertility, because it specifically causes this disorder, which is like another way that it causes female infertility. But this can be painful. It can, just unpleasant. It can cause hair growth on the face. It's not, I mean, you don't have to be obese to get this. Sometimes obesity comes along with it, um, can increase the risk of it. So it's associated. And then the last genitourinary one I have is urinary stress incontinence. So that's, it affects women more than men, much more than men, actually. This is when you basically are peeing yourself, usually not huge volumes, but you can't hold the pee in, right? You can't hold your urine in and you leak some out. It's more common in women after pregnancy, older in life, men also older in life, but the risk of it is increased by obesity, right? Um, Next group, psychiatric. So that's our stuff, right? Depression, anxiety, and there's a lot of bidirectional stuff here, right? What we do know is that obesity can increase your risk of depression, anxiety, and even psychotic disorders, of all things. Um, but also, we know that those disorders can make obesity worse. Not just the disorders themselves, but also the medications that treat them. And so there's kind of a bidirectional thing. So if you have obesity, you're increasing your risk of these, which then having the disorder increases your risk of more obesity. And then if you treat it with medications, which I recommend if you need it, can further increase your risk of obesity. And so it's just tied all over there. And then we've got the body image and self-esteem issues. So people that have obesity, they're more likely to get body image issues, body dysmorphia, poor self-esteem, which can then in turn make depression and other stuff like that worse. So, I think people don't think about, obesity's role in psychiatric disorders. Maybe they think it going the other way, where it's like, okay, you have the mental health disorders and that can cause obesity, but it actually can go the other direction as well and cause them. And when we talk about diet, I will talk about the ketogenic diet. I know it's a controversial topic. Um, we know it. We know that it helps seizures, and I have a strong inclination that the evidence that's coming out that it could help with severe mental health disorders, particularly bipolar and schizophrenia, that there is probably something to that. Um, I don't. I'm not aware of any evidence suggesting against it, and I'm seeing evidence coming out in favor of it, but that's incomplete. And so I think that the fact that changing something in your diet could impact diseases as, what I think what we would think of as out of our control as bipolar and schizophrenia, and that a diet could impact that, suggests that there is something metabolically going on that is causing that. Um, they found that people that have obesity are more likely to get these disorders. The connection is not nearly as strong as is with depression and anxiety, but it's there. So, that's why, I mean, it's important for kids too, right? Because they're the ones that are the ones likely to get, it takes a long time. And, they say with schizophrenia that it often begins in the womb, that like you're preloaded for it, and the attacks that you have, and by attacks I mean like attacks to the system that you have over your childhood, are increasing your risk, increasing your risk, increasing your risk, increasing your risk. And obesity is one of them. And if we can mitigate this stuff, it may be that someone who was genetically loaded for schizophrenia never gets it in the first place. I've heard people talk about, if we could figure out who these people are, give them antipsychotics at an earlier age, because we know that treating it earlier decreases the likelihood that it's not going to respond to treatment and that it's going to be more severe and unmanageable. Moving on to the next body system, cardiac system. So a lot of stuff going on in the cardiac system. So it affects cholesterol levels, high blood pressure, and then those in turn cause heart disease, which is, build up of plaques and things like that in our coronary arteries. But not just our coronary arteries, it affects our vasculature everywhere. And then that can cause heart attacks if it's in our heart, strokes if it's in our brain, um, death of tissues and things if it's in our peripheral vascular system, right? So that's super important, the cardiac. Um, so I think people probably think about the diabetes and the cardiac stuff the most. Those would be the things they're most familiar with. And then probably some of these other things are like, oh yeah, I guess I can see that. And then they might be thinking, oh yeah, I never thought about that, but that does make sense. And then some of these you might be thinking, like the psychiatric stuff, you might be thinking, really? I would not have even thought about those, right? And this is part of why I've included it, right? Because this is a psychiatry podcast. Why am I talking about obesity, right? Like, what am I doing here? This is psychiatry podcast, and I'm going to be talking about treating obesity, and I'm going to be talking about obesity meds. There is such a huge overlap here, right? The obesity affects everything. Every single doctor needs to know this, right? It doesn't matter what system this is why I'm going through these chronic conditions that are associated with obesity. It doesn't matter what you treat. Obesity contributes to it. There's nothing. I don't even mention dermatology in here. Um, but I mean, think about dermatology. You get flaps of skin. You can get infections there, right? Um, I'm sure you can get dermatitis and things like that. If you're vascular, if you're overweight and it's causing you to get varicose veins and like affecting your vasculature and your extremities, you can then get skin infections and lesions like that in your limbs. So I didn't. I should probably included dermatology in here, but I mean, just to show you that it affect. And I've got a few more systems. I'm not finished, but it affects everything. It affects everything. And so, like, for me, it doesn't matter what kind of doctor you are. You need to know about obesity and know what to do about it, because to me, it's pretty much the root of most of our health problems that we have today, right? That's not to say that, if you're not obese, you're not going to have health problems. But I mean, we already talked about in the last episode, this is the most prevalent disorder in the United States and increasingly in the world. And it's a leading cause of all cause mortality and all these problems associated with all these organs, right? We all need to treat it. This idea that I shouldn't be giving people GLP-1s or whatever, and I think psychiatry's coming around more on this now. But I mean, I've been on top of this since I'd heard of GLP-1s. Like, whenever I found out about these things and saw what they could do, I've been on it since then, trying to learn everything I could about it. And that's why I want to do this lecture, because I've put together a lot of information on this topic. I've been studying this and looking into it for a long time, and I want to tell you guys about it. And, you know, we're going to talk about other psychiatry connections. You're going to see the psychiatric connections throughout this series. They are there, from the meds we use. I mean, a lot of the meds we use to treat it. Look, I mean, we use bupropion, we use topiramate. I mean, these are, I mean, psychiatric neurological medications. A lot of the meds we use make it worse. We're the leading cause as far as medications are concerned. I'm going to talk about that in a couple of slides from now. So psychiatry is a huge uh, stake in the whole obesity game. But I think a lot of people probably would discount the psychiatry aspect of this, and then the lifestyle factor type stuff that is the one of the best things we can do to treat mental health disorders, medical disorders, and obesity. This is for a lot of this lifestyle medicine stuff. That's totally in psychiatry's wheelhouse, right? Like, these are like, a lot of doctors, you guys don't have time with your patients. I have a lot more time. I have time to go through these lifestyle things. This is counseling stuff. This is therapy type of stuff. This is like relieving stress, improving relationships, right? These lifestyle factors. These a lot of this, I mean, some of it's diet and exercise, which is all of us. We all should know about diet and exercise stuff. But the other things are a lot of stuff that we're counseling our patients about already. So like, the whole obesity game, I mean, I'd like to own it in psychiatry, but like, I think this is everyone's issue and everyone needs to know about it. And that's why I want to include it. And I wanted to include this early. I wanted to do depression first, but then I wanted to hit this one because, to me, this is the root of so many issues. And then a lot of the treatments for it can help with so many issues. So let's start talking about the rest of the conditions associated with obesity. So let's move on to the lungs, the pulmonary system. So big one, sleep apnea, right? Obstructive sleep apnea. This is a massive disorder that is, getting more and more and more folks are getting this. And having obesity is one of the number one causes of this. And if you're obese, your chances of having it go up exponentially. And then sleep apnea is a horrible disorder as far as what it does to your body. Pulmonary hypertension, falling asleep while driving, strokes, heart attacks, high blood pressure, your cholesterol issues. Like, sleep apnea affects all this stuff. So a lot of this cardiac stuff is tied to the sleep apnea, which is, I suppose, a pulmonary issue, right? But I mean, what really is it? It's, you're not getting enough oxygen. That's essentially what's going on, but it's because you've got obstruction in your throat. That, once again, this is a disorder that goes across different systems. And then another pulmonary disorder, obesity hypoventilation syndrome. I think this is the one that used to be called Pickwickian syndrome, named after Pickwick, which was a character in a novel by, I want to say, Melville, but I think I might be wrong about that. But anyway, this is basically obesity hypoventilation syndrome. Some people might get confused with this and sleep apnea, where sleep apnea is an obstruction in your airway, in your pharynx, which is your throat, that is obstructing your ability to breathe in enough oxygen while you're sleeping. Okay. So this is like a tissue in kind of more proximally, right? This is like in your mouth, your throat, your tongue, your uvula, your soft palate, something in this area, right? This is where the problem is. But with the obesity hypoventilation syndrome, this is basically, you're so large that there's all this pressure on your chest, and you have difficulty expanding your chest and breathing in enough. Okay, so that it's a completely different disorder. Has a lot of similar issues, and basically, you're not getting oxygen in both. I'm not a pulmonologist, so like, I don't know the big details between them, but they are different, and they're both affected by obesity. But obesity hypoventilation syndrome, as far as I'm aware, is only caused by obesity, whereas sleep apnea you can have and not be obese. Musculoskeletal, this is a huge one. All right. So chronic pain, right? You're so heavy that it's putting a lot of pressure on different parts of your body, like your joints, um, your tissue, and that causes chronic pain. And then moving on with the joints, osteoarthritis. So you've got more pressure there. It's wearing away at the cartilage. It's causing pain. And so this is bad because we get these musculoskeletal issues, and now we're like less likely to exercise, which affects our metabolic health more. And so it's kind of like the psychiatric thing where we have a problem that causes a problem that then, in turn, that problem can then make the other problem worse again. Okay. And that's the case with a lot of these. And then let's go with obstetric. So this is, not a fertility issue. The patient's already pregnant at this point. There is a higher risk of neurodevelopmental and psychiatric disorders in the children of obese mothers. Okay. So the mom being obese can affect the baby. So neurodevelopmental, that means like kind of it could affect their IQ, it could affect ADHD type of stuff, these type of disorders, right? And psychiatric disorders. All right, and then the last one I'm going to go into more detail on is that it increases the risk of 13 different types of cancer. I think a lot of people don't realize this, especially those of you that aren't doctors out there. Obesity increases the risk of 13 types of cancers. Let's go into more detail on that. So I think this is going to blow you away. More than 684,000 obesity associated cancers in the US each year. That's more than 500,000 people are getting cancer that is associated with being obese in the US every year. Do we know if it's a direct cause? There's no way of knowing that. But we do know that these are cancers associated with obesity, and these are people that have obesity and they're getting these cancers. So we believe, and that they're getting it at higher rates than those that are not. Okay. Let's break it down men by women. Women are more affected by this. That's because a lot of these cancers are female cancers only. Okay. So 470,000 of those 684 are in women, 210,000 in men. The number one cancer, obesity associated cancer for women, no surprise here, it's the number one cancer women get, breast cancer. For men, colorectal cancer is number one. All right. So why does this happen? So we'll go through this, and this will be kind of why a lot of this stuff happens. All right. So this is what's going on here. You have the inflammation, right? I talked about the inflammation a lot. So you have this long-lasting inflammation that leads to oxidative stress, and that causes DNA damage. Damaged DNA is at risk of becoming cancerous. Okay? All right. So you also get an increase in adipokines, which then stimulates cell growth. Cancer is uncontrolled cell growth. Okay? So you also get an increase in insulin, which is bad for cancer. You get an increase in IGF-1, which is a growth factor. You get an increase in estrogen, which can affect cancers that are affected by estrogen. And you get an indirect effects on other modulators like mTOR, AMP activated protein kinase. So as you can see, obesity causes a lot of things that all increase your risk of cancer. And a lot of that stuff increases your risk of those other problems we talked about. Let's go through the list of the 13 cancers. Meningioma. It's a cancer of the tissue that covers the brain and spinal cord, 1.2 to 1.5 times increased risk. Adenocarcinoma of the esophagus, 2 to 3 times increased risk, 4.8 times increased risk for severe. All right, 30.6% of adenocarcinomas of the esophagus are obesity related. That's a lot. All right. Multiple myeloma, That's a cancer of blood cells, 1.1 to 1.2 times increased risk. Kidney cancer, 2 times increased risk. This is the biggest one, uterine cancer, 2 to 4 times increased risk, 7 times increased risk for severe obesity, accounting for 49.2% of uterine cancer is obesity related. So if you're not obese, you're still at risk of uterine cancer, but you are 7 times less at risk, and half the cancers are in those that are obese. So you've cut your chances of getting uterine cancer by quite a lot. I'm going to do the math on exactly how that works backwards, but like if half the cancers are caused by obesity and you're not obese, you're not in that half, and so now you're only in the other half that's at risk, right? So that's significantly cutting your risk. Ovarian cancer, 1.1%, 1.1 times increased risk. Thyroid cancer is 1.3 times increased risk. Breast cancer in postmenopausal women is 1.2 to 1.4 times increased risk. Liver cancer, 2 times the increased risk. But remember, we talked about fatty liver, right? And how that can lead to cirrhosis. It can also, those same factors that can cause those cirrhosis can also cause liver cancer. 51% of liver cancer is associated with obesity. So, I mean, this whole thing about having fat in your liver, something that didn't really happen in the past, and now it's happening all the time. Gallbladder cancer, 1.2 to 1.6 times increased risk. Upper stomach cancer, 2 times increased risk. Pancreatic cancer, 1.5 times increased risk. And I don't know, not increased, but 1.5 times the risk. And then colon and rectal cancer is 1.3 times. So as you can see, there are 13 cancers, many of which have a pretty substantial increased risk. All right, let's go over how to do an assessment. Patient comes to your office, doc, I'm worried about my weight, or you look at them and you evaluate their chart and you're worried about their weight. Before we treat them, how do we assess them? Well, first we want to know what their weight is, but there's lots of ways to do this. BMI, right? The body mass index. We talked about that. It's not perfect, but it's a decent screening tool. Waist circumference to me is probably your best easy option. And so this is, and it doesn't really matter what your height is. If you're extremely short or extremely tall, it might be affected, but within the vast majority of people's height ranges, the waist doesn't really change. So as you get taller, your limbs are getting taller, your torso is getting longer, but your waist is not increasing in size. Okay, so obviously, if you're 4.5 feet tall, 4'10", something like that, you could definitely be extremely petite and have a very small waist. And if you're 7.5 feet tall, you're probably going to have a bigger waist. But for the vast majority of us, this waist circumference is a good tool. And the cutoffs are equal to or over than 35 inches for women and equal to or over 40 inches for men, which, I mean, that's kind of distressing, I think, because I think women often tend to be on the heavier side, especially since they have, bigger hips and more fat in their hips. But we're not talking about the hips here. We're talking about the waist. But sometimes that weight can be up on the waist too, right? And so it's 35 inches for women and 40 for men. That would be where you would be concerned at that point. And also when we talk about metabolic disorder, one of the 5 symptoms is waist circumference. It's not BMI, and these are the numbers we use. All right, so you can do a waist to height ratio is another one. And then probably one of the best things would be body fat percentage. And there's a couple of ways you can do this. There's a professional way to measure this where you use calipers, which is a little tool that you like pinch the skin. There's an easy one where you can just do like periumbilical. So this is just like from your belly button to the side, you pinch. Chest, it's like up towards your arm. You is where the skin you pinch on the chest. And then the thigh, it's like on the top of the front of the thigh. not at the top. So like the front and the middle, you pinch there, and then you measure the millimeters and you put them into a calculator, or formula, and it tells you what the body fat percentage is. And there's one that's a little more accurate. That's like 7 points. Um, it's best to get this done by someone who knows how to do it, so that but I estimated my own like this. I basically just pinched my skin with my fingers and used a ruler, not calipers, and I calculated it, and then I went to a machine that calculated it, and it was pretty close. So I mean, if you're good at measuring it, you may be able to do it yourself, but like I wouldn't rely on that. But what you can do is get a bioelectrical impedance, and the gyms that I've used, they have one of these machines, and it costs like a few dollars to use the machine. Essentially, you stand on it, you hold something. It tells you a lot of information. It tells you like how much visceral fat you have, how much muscle mass you have, how much fat you have. It gives you a lot of readouts, and it gives you some recommendations of like you should gain this much of this or lose this much of this and so forth. And you can kind of use it if you're going to the gym to track how well you're doing, because I know we all want to look like sculpted and buff and all this stuff, but really you just want to have a healthy body fat percentage. And 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 for women, you get to be higher for this. For men, I would say good would be kind of in the 10 to 20% range. um, Bodybuilders are down at like 3-4%, which is like really challenging, and I would not be striving for that. um, 5 to 10% would be like really lean, but that doesn't necessarily mean you have muscle, and it's hard to gain muscle and lose fat. Like it's really challenging, right? So I think that 10 to 20% is a good range. um, Once you get over 20%, you've got too much. You don't have a lot, but you probably have too much. And then for women, it's more like the 20 to 30% range. So like female bodybuilders are around the 10 to 12 range. So it's just women have more fat on their body. It's what you're supposed to have. So don't feel bad about it. I mean, your waist is supposed to be thinner than men's, but you're supposed to have more body fat. So you can use one of these machines, and they have these in a lot of doctors' offices. So a lot of offices will have these too. Um, and then the gold standard is, and I'm gonna forget. It's like a full body scan thing. I think it's a DEXA scan. So it's like the scan they use to check for bone mineralization for like osteoporosis. That is the gold standard, but like we can't give these to everyone. But that's what they use when they're doing like scientific research. And so the other thing we want to do is get a weight history, kind of know like what has your weight been over time, and then you get social history, family history. Does your family have these disorders that we've talked about? Do they have obesity? That puts you at risk. Um, Check their life. The social history. We're going to assess lifestyle factors because we're going to use lifestyle techniques to treat the patient. So we need to assess what their current lifestyle looks like. We'll go into that in a lot more detail later, like how are they sleeping, how are they eating, how are they moving around, those sort of things. So they have stress in their lives. We need to assess that before we can coach them on how to fix it. All right. More stuff in the assessment. You're going to want to screen for some comorbid conditions. So all that stuff I mentioned, we're not necessarily going to screen for all that, but we're going to screen for the big ones: cardiovascular disease, diabetes, um, high cholesterol, high triglycerides, blood pressure, sleep apnea, fatty liver, um, GERD, heartburn, depression, anxiety, poor sleep, chronic pain. Right? You're going to want to look into these because these are effects of having obesity. And you've got someone in your office, you basically have seen, oh, this person's obese. We figured it out. We did the measurements. We need to look for the most common problems that they could have from being obese, and then we're looking for metabolic syndrome. Also, this is something where it's like if you've got high blood pressure, you've got kind of your glucose is in the pre-diabetes or diabetes range, your triglycerides are high, your HDL, that's your good cholesterol, is too low, your waist circumference is too high, and you're and this is without meds. So like if your blood pressure is controlled but you're on blood pressure medication, that counts as having a blood pressure problem. So 3 of those 5 and you have metabolic syndrome, right? and this is a scary thing. So, University of North Carolina did a study in 2018, and they found that only 12.2% of Americans had none of those symptoms. And even scarier, in 2022, Tufts University did a study that found only 7%. Now, they had a little bit different criteria. Um, they did not include the triglyceride in that one, and they included heart disease instead, which is like a history of, angina, heart attack, stroke, that sort of thing, which to me would have been more stringent. It's like, oh, we're excluding people that have high triglycerides as their only problem, and a lot of people do, and substituting it with basically a result of a lot of these problems. But instead of finding less people that were healthy, they found, or more people that were healthy, they found less. 7%. I'm proud to say I'm in that 7%. But I feel like that it's not a high bar. And this is all adults. This is including people like in their 20s, right? This is adults. 75% are overweight or obese. And so, I mean, metabolic syndrome uses the waist circumference. I think a couple of these studies may have just used overweight or obesity and not waist circumference. But like 75% of people are overweight or obese. So we're already down to 25% now, right? And then when you throw in having cholesterol issues, blood pressure issues, glucose issues, you knock a bunch of other people out. And then you're down to 7% that don't have any of this. It's not many. This affects everyone. I mean, this is why we need to pay attention to this. Only 7% of people have good metabolic health, right? And so the next thing we want to screen for are things that might be causing the obesity other than lifestyle factors. So lipedema, something that you may not have heard of. This is like a deposit of fat under the skin. It's something that can't really be helped by lifestyle factors, and the medications don't work that well on it. I'm going to talk about it at the end. It's something I didn't know about until a couple years ago, something that I wasn't taught about in med school, but it's something that can make you like appear to be obese, but it's a different type of tissue. It has a different set of issues with it, and the treatments are different, and they're also less effective. So you want to make sure you're treating someone for obesity that they don't have lipedema, because then it's not really going to work. You need to treat that illness. Cushing syndrome. So this is a disorder where you have too much cortisol. It could be caused by lots of different factors, but it causes a whole host of symptoms, obesity being one of them. So should be something that is on your mind. Usually someone has a particular appearance and certain set of symptoms that would cue you up to test for it. It's not very common. Next, secondary hypogonadism. This is also not very common. This is a disorder where you're not making enough sex hormones in your pituitary. So that's could be a cause of low testosterone, because testosterone is produced in your testes, but it's, kind of signaled from your pituitary. So this is we're not producing FSH, we're not producing LH. And it's like a pituitary problem. This is a very rare disorder, but it can cause obesity. And there would be other symptoms to kind of assess to make you think that this was happening. Of course, if someone's having fertility issues, sexual complaints, and you're checking things and you're trying to find the root cause of that, you may find out that it was secondary hypogonadism. That could be a cause of their obesity. Hypothyroidism. Thyroid stuff is easy to check. If somebody's obese, thyroid should definitely be something that we're checking. And then PCOS, I mentioned that before, polycystic ovarian syndrome. That's something that has a set of symptoms that you should be able to notice and check for. That can also cause obesity, and the treatments may be different. All right, so we want to make sure there's not an underlying cause of the obesity that is a different medical condition that we need to address, right? Because, of course, if you have some other illness, we want to fix that. And then I would screen for other medical conditions that may affect what med we choose. Some of these conditions may say, don't pick that med. And some of them might say, hey, you might want to pick this med. All right. So like migraines, topiramate, Qsymia that contains topiramate is a treatment for migraines. So if they have migraines, hey, maybe that's a treatment you might want to use. Constipation, GLP-1s can cause constipation, so you might want to be careful with that. Diarrhea, if you have diarrhea, having a little bit of constipation may be helpful, so maybe that would make a good thing about the GLP-1. MIN2, that's multi-endocrine neoplasm type 2. This is an extremely rare disorder that increases your risk of medullary thyroid cancer, which is a really rare type of thyroid cancer, but it's a black box warning for GLP-1s. So it's like, if you have this problem, you can't take a GLP-1. It's really rare. The patient would probably know if they had it, unless it was early on. But it would be something you would not check for this. It's a very, very like 1 in a million type of thing. But it's a black box warning, so you need to know about it. Seizures, so like if they're taking something with bupropion in it, not appropriate for seizures. So you'd want to know if they have a seizure disorder. Glaucoma, anything that could cause like high blood pressure, like a bupropion or phentermine, may be a bad for that. So you'd want to know if they have glaucoma. Kidney stones, GLP-1s can affect that. So you kind of want to know that not necessarily that you wouldn't want to give it, but you'd want to know about it. Bulimia, anorexia, so like eating disorders, bupropion is a no-no with those, increases seizure risk. So, you'd want to know about that. But of course, they're not going to have anorexia if you're assessing them for obesity. Anorexics are not normal weights. Bulimic patients can be normal weights, or overweight. So that would be something that you want to have an eye on if you're thinking about using bupropion. Also, not healthy to give people weight loss medication that have eating disorders. Also, that's bad. And I watched a show like in Australia, and it's probably going on in the United States too. But it was a episode of 60 Minutes Australia where like they're basically just like having call-ins to give them GLP-1. So they're like, it's like virtual medicine. They don't even see the patient. They send in a picture of themselves, which, so basically people with eating disorders could like sneak their way into getting these GLP-1s. So like, I don't like this idea. I hate the idea that you would not see a patient physically to treat them. And if you're giving somebody a medication that, not knowing what they look like, could affect what treatment you give them, then you should probably look at them. All right. And that's most stuff. And then pregnancy. Most of these drugs are not okay in pregnancy, except metformin, which is not even FDA approved, but it's something you can use. But yeah, most of them are not okay to use in pregnancy. That's not necessarily because it's going to cause problems, but because we don't know if it's going to cause problems. And then another thing in assessment, you need to assess their motivation and expectations for weight loss. How much do they think they're going to lose? How much do they want to lose? What's realistic? It's probably the patient's going to be unrealistic, and they're going to be like, I want to look like I looked when I was 20, or I want to lose 100 pounds and I want to be 150 pounds, probably, not realistic. And so we need to know what their expectations are so that we can work with them to set realistic expectations and then work towards something that's realistic. Because if they don't achieve their goals, they're going to give up. And we don't want them to give up because this is improving their health, right? And we're putting all this energy to help them do this. So we want them to stick with it, right? And then, some basic labs I'd probably get on all these patients. So if we're doing an obesity assessment, we're probably going to want to get an A1C. That's a diabetes, lab to check for diabetes. Or you could also get a fasting plasma glucose. I usually get them both because I'm getting that with the comprehensive metabolic panel, and I just have them do it fasting. So I have a fasting glucose. I'm going to get that back sooner. It gives me another point of data. So I'm going to want to get a comprehensive metabolic panel because that's also going to tell me what's going on with their liver. It's going to tell me what's going on with their liver and their kidneys, and it's going to tell me what's going on with their glucose. So those are all things that we want to assess for. I'm going to check their thyroid, and I'm going to check their cholesterol. Those are the big ones because those are the problems that are most likely to be associated with obesity. These rare conditions, I'm only going to work those up if I have a suspicion for them. And then I just want to go over here briefly. If I have a comprehensive metabolic panel that comes back with elevated liver enzymes, um, what might I do? Right. So obese patients and those with diabetes usually are going to have a fatty liver. They're going to have the NAFLD, right? 20% of them are going to get NASH, um, which is hepatitis associated with that. Okay. So it's quite common. And the reason why I might bring this up now is that the likelihood that this person has fatty liver is is pretty likely if they're obese. And then 20% of them are going to get metabolic dysfunction associated uh, steatotic hepatitis. That's a really bad disorder. The MASLD is not dangerous. It's kind of like pre-diabetes, right? It's like a sign that like we could get MASH and cirrhosis and cancer, but we're not at risk now, but we're like getting there. We're packing fat into our liver. It hasn't started causing the problem yet, right? But 20% of them are going to get hepatitis. And that means from there, you're going to get the cancer and the cirrhosis with a smaller percentage. But because so many people are going to have this, you should know what to do with it. Like when I assess this, I get a lot of liver enzymes that are elevated. And then like as a psychiatrist, do I know what to do with that? Right? I need to work it up. So first we need to rule out alcohol because we're saying this is not alcoholic associated, not, alcoholic fatty liver. We need to make sure it's not alcohol. Assess that, get a PEth, it's a blood test to check for their alcohol use, get a GGT, get whatever you want to get that you feel like is appropriate, assess their alcohol. If you're concerned that things have gone really far and they might be, getting towards cirrhosis, run a FIB4 score to evaluate for that fibrosis, FIB4, you can look that up. And then you're going to want to rule out other stuff, right? So we've already ruled out alcohol. We need to rule out other things. We need to make sure, because the thing is, we just found that they had elevated liver enzymes. We can't just assume it's because they have fat in their liver. We have to figure out, like, if it's not something else. So make sure it's not the alcohol, and if it is, address that. We need to look for hepatitis. We need to do a Hep B and a Hep C screen. So we need to get a Hep C antibody, a Hep B core antigen, and a Hep B surface antigen. Another common cause is alpha 1 antitrypsin deficiency. So I would check that. Autoimmune hepatitis. If their levels are more than 5 times normal, then I would check for autoimmune hepatitis. So I'm going to get an ANA. I'm going to get an anti-Smith antibody. There's some other antibodies. I'm probably not going to take it that far. IgG1 kidney liver, and then I'd probably leave it there. And if I'm still suspicious this stuff comes back negative or it comes back positive, I'm going to send them to somebody else. But I like to do the initial workups myself because they may not get to see, a hepatologist or whoever they need to see to treat this for like 6 months, and it's like, they're in my office now. I'll run the labs. If they've got autoimmune hepatitis, they can probably get in to see that hepatologist a lot earlier, right? I'm probably going to send them to, internal medicine or GI or something they can get into. And then we need to get them to somebody who can deal with this situation because it's not me. I'm not going to give them methotrexate or whatever the heck it is you use to treat autoimmune hepatitis. I have found this once. I had a patient do an obesity assessment, and this is one reason why I'm talking about this, because this happened to me. And we had super high liver enzymes, and I was like, wow, that's a lot higher than I would suspect from obesity. And I ran these labs for autoimmune hepatitis. Turns out that's what she had. She's got obesity, but she also has autoimmune hepatitis. So you don't want to just assume that, it's like a patient comes in, we get these patients coming in that have schizophrenia and they're psychotic. And then we can't just assume that they're like psychotic right now because they have schizophrenia. Maybe they have an infection. Like, that's why we need to check these other stuff. You can't just assume that the most common thing explains it when there's something that could be killing them that we're not doing anything about. All right. So make sure, because this woman actually had this for a while. I looked at her like past lab, and she had elevated enzymes for a long time, and no one was doing anything about it. They're just, oh, she's overweight. That's what it is. They didn't get this high though. But I checked it. We found it. she's getting the treatment from someone that knows what they're doing to treat it. I have a pretty good idea how to find it, but I'm not the appropriate person to treat it. So like this is, I do draw my line some places. I like to do as much as possible, but I do draw my line. And then there's lots of medicines that can cause increased liver enzymes: tamoxifen, amiodarone, corticosteroids. Um, Look on livertox.gov if you want to find an exhaustive list. And then there's some other conditions that I probably wouldn't screen for initially, but I'd have in the back of my mind in case other things look like it might be this. So other causes of increased liver enzymes: Wilson's disease, super rare. I've never seen it before. Um, can't get rid of copper, causes psychosis, liver problems, Kaiser-Fletching rings. You guys probably know this. It's one of those things that you never see, but you get tested on constantly. Celiac disease, that's not that uncommon. If so, I'd be assessing kind of for that. I wouldn't check the labs unless I was tipped off for something other than liver enzymes being increased. But I mean, increased liver enzymes is not like something I think about with celiac disease as like a primary thing, but it is something that could happen. And then like hemochromatosis is another one. So like you might want to consider checking ferritin transferrin saturation. Um, the guideline I have is to check in Caucasian males for sure, and maybe in females as well. That's a pretty easy one to check. Um, but like we don't want to go checking willy-nilly things all the time. So that's something that like if their liver enzymes are increased and we don't really know what it is, and we've checked a lot of this other stuff, that's something else that you might want to consider. There's not going to be, with that one, unlike some of the other things, we're not going to have the symptoms that are tipping us off. That's something that kind of can lie in there dormant, causing problems for a long time before it pops up. And those increased liver enzymes may be our sign. All right. And I'm also going to assess what medications they're taking, right? Because the meds they're taking can cause obesity as well, right? And most of these are my meds, right? So we got antipsychotics, um, clozapine being the biggest offender, followed by olanzapine, followed by quetiapine, followed by risperidone, followed by the rest of the second generations. Pretty much any of the second generations can cause obesity. Um, that's something you're probably not going to miss, right? People are pretty keyed in on that. Um, Next, antidepressants. Um, I see this one. I see mirtazapine. We talked about mirtazapine, tons of episodes ago. I see people that are overweight and obese before they take mirtazapine all the time, and I'm like, why did this doctor tell you could gain more weight? I'm gaining all this weight. I'm like, you were already heavy. Why did they put you on mirtazapine? It's the worst. It's the worst of the antidepressants for weight gain. Um, Followed by tricyclic antidepressants, followed distantly by selective serotonin reuptake inhibitors. Paroxetine being the worst of those, which is the one that you really should pretty much never use anyway, but I see it. It's the one that can cause weight gain. And then MAOIs. So pretty much any of the antidepressants can cause weight gain, some more than others. And then more of our meds, anti-epileptics, which are also the mood stabilizers. Worst offender is divalproex, valproic acid, followed by carbamazepine, much further down. Divalproex is a massive one. Then carbamazepine, lithium, mostly water weight, gabapentin and pregabalin a little bit. And then antihistamines, which we also use quite a lot. So diphenhydramine, cyproheptadine, we don't really use that one. But diphenhydramine patients will take that for allergies, sometimes for sleep every night. I wouldn't recommend that. It can also cause like cognitive dysfunction. Alpha and beta blockers, so those are heart rate control medications. I use them for PTSD, nightmares, hypervigilance type of symptoms. The weight gain there is probably due to exercise intolerance and fatigue, so they're not working out as much. And then we've got our diabetes medications, so like we've got glucocorticoids. Then we'll talk about diabetes medications. So like prednisone, methylprednisolone, hydrocortisone. Some folks are on those chronically, and that can like basically induce kind of like a Cushing syndrome type of situation. Whereas Cushing's is like you're producing the corti the corti the steroids, whereas this one you're like taking them. Um, and then the diabetic agents, so like insulin, but most of these are the old ones. So insulin, sulfonylureas, those are the worst, followed by uh, meglitinides, which is stuff that ends in glenide. I never see anyone on this. In fact, I never see anyone on sulfonylurea either. There are patients on insulin, obviously, especially if they have type 1. And then we've got the let's see if I can say this, the TZDs. These are the glitazones, the thiazolidinidazone. Man, I missed it. Thiazolidinidazone. That's just a hard word to say. But those are your glitazone medications, and you will see those occasionally. And then hormonal agents, somewhat controversial, progestins, which is found in birth control pills, and medroxyprogesterone. We're not quite sure, but that may have some impact on weight. And then I just wanted to, when we wrap up, let's talk about how some of those meds cause those problems. So when we're talking about antidepressants and antipsychotics, and the antihistamines for that matter, for this first one, antagonizing the H1 receptor, the histamine receptor, decreases your metabolic rate. Serotonin, 5-HT2C antagonism. That's what second generation antipsychotics do. It decreases your satiety signal, so it makes you feel like you're not full. Increases your carbohydrate craving, which is the kind of calories that will cause weight gain. These meds also, especially the antipsychotics, can increase prolactin. There's anticholinergic activity in a lot of these meds, which affects glucose and insulin. And there's actually might be some effects on GLP-1 receptors. Most of this is antipsychotics. Okay, so there's a little bit of effect with serotonin with the antidepressants, and some antidepressants are anticholinergic. Some, have some of these, but this is mostly antipsychotics causing those things. That's why they're typically much worse. Mirtazapine has H1 antagonism and 5-HT2C antagonism, so that's why that one's so bad. And then the glucocorticoids, the reason why they cause weight gain is they increase your appetite, lower your metabolism, drive storage of adiposity, which is fat, into your abdomen. So that's how they do it. Most people are not on those chronically unless they have some sort of like a disorder that needs inflammation controlled a lot, and their other meds are not working for that. And then the diabetic agents, so like insulin. So insulin, we don't want people on insulin because it causes weight gain, right? So let's, you want to treat them. That's why GLP-1s are so great. They cause weight loss. They treat diabetes. They prevent us needing to use insulin. So insulin leads to storage of glucose, which can cause weight gain. And also, people will eat to avoid low blood sugar. That can lead to weight gain. The sulfonylureas, which are not really used, I never see these anymore. They force the pancreas to produce more insulin, aka, which is why it causes weight gain, because we just talked about insulin. And then the thiazolidinediones, like pioglitazone, they help healthy fat cells store fat. They cause water retention, but the weight gain is relatively healthy weight. Even they gain a little bit of weight, but the type of weight they gain is not really the unhealthy weight. They won't like the weight gain, but I've actually, heard that pioglitazone is a pretty good medication to add on if whatever else they're taking is not doing the job. So, hey, that was much longer than I thought it was going to be. But we talked about conditions that can be associated with obesity, things that can cause be caused by it, cause it. We talked to I talked a lot about the psychiatric conditions, and then we went through a thorough assessment. We talked about like how to assess for weight, social history, other disorders that could be caused by obesity, what to screen, what disorders you should be screening that could be causing obesity, things that could be affecting the med choice you make to treat the obesity if we're going to use a med, the basic labs I would check, what to do with high liver enzymes in particular, because I think especially psychiatrists may not be familiar with that. And then we went over all the medications that can cause obesity, and so like obviously if you can change that med, you should do so, right? I mean, if someone's on olanzapine for psychosis and nothing else works, then we're stuck with it. That doesn't mean we can't give them a GLP-1. or other medication. I mean, I would probably go with that one. But some of these we're going to be stuck with. But if you haven't tried another med and it's less likely to cause it, let's try it. You know, I think people are afraid to mess with people that are psychotic. It's like, I don't want to mess with this and cause them to be distable. It's like, yeah, but what idiot put them on olanzapine and never tried anything else and never tried to put them on something else? You're just going to let them sit on this medication for the rest of their life? No one starts with clozapine. If you end up on clozapine, you need clozapine. But these other meds, something else should be tried. All right. I mean, you're going to give someone mirtazapine, they gain weight and not change it? That's insane. Okay. So, and you know, you're going to give someone divalproex and they gain a whole bunch of weight and we could have given them lithium. Like these are things to think about, right? Sometimes we need to give some of these heavy hitters um, to get symptoms under control when things are acute, and then we can change them and lower them later. Sometimes we just lower the dose. You know, maybe they don't need 20 of olanzapine. Maybe 10 would be enough. You know, maybe they needed 20 when they're in the hospital and they need 10 now. So, like, you can adjust doses, you can adjust meds, you know, we can cross taper over to other things. Because, look, if we cause them to be obese, look at all the problems. They haven't even done this themselves by poor lifestyle factors. They've done it, we've done it. And now they're at risk of 13 types of cancer and like 50 different illnesses. That's not cool. But, you know, let's not be the cause of that. So, you know, it's a very exciting episode. I hope you enjoyed it. We're gonna start digging into treatments. I'm gonna start hitting diet next time. It's probably gonna be several episodes, but I will do an ADHD episode next time, and I'm gonna throw in another update. So we did the July updates. I got a September updates. I think you're gonna like it. We got a lot of new information, some new drug stuff coming out. We'll do a quick, you know, little 30-minute thing there probably. Go over those little quick takes. I got like 14 things to cover. I think you'll enjoy that. I just want to mention, I forgot to tell you what song I was doing last time. I picked the Sum 41 song. I love Sum 41. The song Motivation. Thought Motivation would be a great song for ADHD. People don't get motivated. You know, sometimes motivation is an issue. And then with today's song, I'm going with the fat theme. The song is Fat Lip, which is not about, you know, being overweight, but it's another Sum 41 song. It's a great song. It's got the word fat in it. Makes sense to me. You know, go download it on your own. I download all these songs. They're awesome. And I hope you enjoyed our episode, and I will see you next time.